Good evening to everyone present here with us today. This is Shreyan from IGCP, today's moderator. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by our keynote speaker, Doctor, for today's session. With much pleasure and honor, I would like to welcome a very renowned doctor, Dr. Deepak Govil. Sir is MBBS, MD, European Diploma in Intensive Care, Vice Chairman at Critical Care Unit at Medanta Hospital, Gurgaon. With the help of Sir and his wonderful insight, we will be taking a close look on today's topic, which is management of acute respiratory distress syndrome. Now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him. Over to you, Sir.
Thank you, Shireen. What is the problem? Can you see the slides? Not yet.
No, sir, not yet. You can't.
We checked what is the problem. Mhm. Moves away. Not yet.
Yes, sir. Your slides are visible. Just move to the slides part. Yes, sir.
Yeah. So, good afternoon, dear friends. Today, I'm going to talk about the management of acute respiratory distress syndrome, which we call as ARDS. So, as you all know, the ARDS was first published. The term was first published in Lancet in 1967. So, it's close to around maybe 56 years from today. And the main authors were Ashbog and Bigelow. So, Ashbog and Bigelow coined this term, along with Petty, coined this term in 1967. So we are going to talk about the in last 57 years or so what happened, the definition, pathophysiology, pharmacological therapies, mechanical ventilation, active fluid management, and mortality. I'm going to talk about this. So original definition, which was published in 67, was a case clinical pattern that includes severe dyspnea, tachypnea, cyanosis that is refractory to oxygen therapy, loss of lung compliance, and diffuse alveolar infiltrate seen on the X-ray chest. So this was there. Then in 1988 there was lung injury score came in. Then in 1992 there was a AEC definition of acute lung injury, and ARDS came into this. And now what we are following since 2012 is the Berlin definition of acute respiratory distress syndrome, where they have divided ARDS into three categories: the mild, the moderate, and the severe one. In mild category, the PF ratio, what is that, is the partial pressure of oxygen divided by the FiO2, is 200 to 200, 300, with PEEP of or CPAP of less than 5. In moderate, the PF ratio is 100 to 200 with PEEP of more than 5. And severe form of acute respiratory distress syndrome, the PA and FiO2 ratio is less than 100 with PEEP of more than 5. So this is the definition. Pathophysiology could be the primary injury, then there is a host response to that injury, and then there is a consequence of that therapy. So these all, when they are there, it becomes the pathophysiology. The direct injury could be because of the bacterial, viral, fungal, or opportunistic pneumonia, aspiration of gastric contents, pulmonary contusion, inhalational injury, and near drowning. Indirect lung injury factors are sepsis, then non-thoracic trauma or hemorrhagic shock, pancreatitis, major burn, drug overdose, transfusion blood products, and cardiopulmonary bypass, reperfusion edema after lung transplantation. So these are there. Then there are certain conditions which may mimic as ARDS, like congestive heart failure, like interstitial lung disease, like connective tissue disease such as polymyositis, diffuse alveolar hemorrhage from vasculitis or Goodpasture syndrome, drug-induced lung disease, including the vascular leak syndrome from immunotherapy, what we call it as a CAR T cell lymphomas and metastatic carcinoma, and then endobronchial tuberculosis. So these are the mimics. What happens in ARDS is alveolar capillary membrane is damaged. There is an alteration in surfactant production and the surfactant homeostasis. Neutrophils are very important in this, and there is a defective sodium clearance. Coagulation becomes more. The microvascular coagulation takes place, and the final thing is the ventilator-associated lung injury in the ARDS. So this is how it happens. Mortality in ARDS, if you see in this chart, this is a little old slide published in Current Opine Critical Care into around 10 years back. The mortality to start with was 70% and gradually coming down to 40%. But during the COVID pandemic, we have seen the mortality has gone up again, but it has coming down back to the this figure. Management, there were so many medical pharmacological therapies were tried in the ARDS, starting from the anti-inflammatory drugs, steroids, surfactants, and so many drugs. But no drug has shown to be effective in ARDS till date. So we are still in the waiting. We are still waiting for a miraculous drug which can be a beneficial in ARDS. So ARDS management mainly remains supportive with mechanical ventilation forming the cornerstone of therapy. It is clinically challenging because mechanical ventilation, which is immediately life saving, may exacerbate lung injury and increase mortality. So, in this case, mechanical ventilation is a double edged sword. Whereas it is one of the main cornerstone of the therapy, just as a life saving therapy, but this can worsen the lung injury and increase mortality. As I have already enumerated in the causes of ARDS and the pathophysiology, ventilator associated lung injury plays a major role. So, as we all know, the goals of mechanical ventilation are minimize iatrogenic lung injury, provide acceptable oxygenation, and acceptable carbon dioxide clearance. So, these three are the main goals of mechanical ventilation in ARDS. Coming back to the non-invasive ventilation and high-flow nasal cannula in ARDS, so this paper was published around 8 years back in the American Journal of Critical Care Medicine, and where they have seen that NIV seems to be associated with higher ICU mortality in patients with severe, moderate to severe patients of ARDS, but in patients of non-severe ARDS or mild ARDS, we can try in these patients as an IV. So, can we prevent intubation in patient with ARDS by using NIV if the PF ratio is more than 300? Mild respiratory acidosis, we should give HFNC trial for 1 hour. If it is improving, well and good. If it is not improving, we can evaluate the non-invasive ventilation for 1 hour. And if it is not improving, then please intubate these patients. Don't prolong this NIV support for too long, because as you know, if patient is becoming uh, more unstable at that point of time, the emergent ventilation intubation will cause more, has got more complication than an elective intubation. So rather than intubating when NIV has failed, we have to intubate little early. What are the ventilation strategies? So, key features in ARDS, what happens in the ARDS? There is a decrease in lung volume, impairment of respiratory muscles, heterogeneous distribution of loss of aeration, high airway pressure, and with this milieu, when we try to ventilate, there is obviously risk of ventilator induced lung injuries there. So, what is Willy? If we talk about the Willy, it is mainly the ventilator associated lung injury, where because of the shear trauma, shear injury, and over distension of the lung. So, if we talk about the lung in the ARDS, as you can see, the white part is a consolidated part in the CT scan. Here, if you can see, this black is only aerated, and these are the less aerated, and this part is densely consolidated. So, what is happening? Normal aerated, poorly aerated, and non-aerated part. So, as you can see, there is a baby lung. This baby lung concept was introduced in 80s. What happens that if you see this ventilated part, the smaller part which I have shown here is hardly any. So in an adult, if you compare this to a ventilated part, it becomes a baby lung. This part is not ventilated at all. So this whole becomes a baby lung. And this is around a 5 to 6 year old child. The dimensions are so. Then there is a concept to provide a gentle lung treatment. So if imagine if we are giving a ventilation as per adult to a baby, what will happen? His or her lung are going to explode. Same thing happens here. So smaller baby lung, greater is the potential for unsafe mechanical ventilation. But mind you, this baby lung is present in an adult. This part, because the functional lung is become very less. So we have to ventilate this patient very gently. Otherwise, what will happen? This area, which is the relatively normal, will also deteriorate. So as you can see, this area is having risk of overdistension. It could be a barotrauma or volutrauma, and that's how we started measuring the tidal volume and plateau pressures in these patients. And as you can see, there are multiple studies supporting the low tidal volume and plateau pressure less than 30. Again, lungs in a, as you can see here, this middle zone is a recruitment area where we can apply some PEEP, we can recruit it. But mind you, the moment patient expires this area, de-recruited. So what happens here? There is a repeated recruitment, de-recruitment, recruitment, de-recruitment, and all this is leading into atelectrauma. So again, this is a problematic area. Here comes the role of PEEP. We apply the PEEP. PEEP is a positive end expiratory pressure, so it applies only in the expiration, and this PEEP keeps alveoli open at the end of the exhalation. And PEEP is a compromise between lung stretching and lung recruitment, because if we are applying more PEEP, lung is getting stretched as well. So, how to select PEEP? Again, it is a very difficult question. People have spent their whole life to identify how to select ideal PEEP. But as you can see here, at this point, lower inflection point, the alveoli is like this, it is getting collapsed. So, atelectrauma is happening. Whereas, if we go up beyond the upper inflection point, this is a volume versus pressure graph of ventilation. So, if we go beyond the upper inflection point here, as you can see, the alveoli the alveoli are getting hyperinflated. So we have to select somewhere here where neither my alveoli is getting collapsed and nor it is hyper inflated. Open lung concept now comes in the picture. The open lung is one in which there is a little or no atelectasis and an optimal gas exchange takes place. So establishing and maintaining patency of all recruitable air space during respiratory cycle is maintained. It is first proposed in early 90s. Dynamic process of opening previously closed alveoli unit by increasing transpulmonary pressure. So that is what we call as a recruitment. So this was the paper which was published few years back, around 15 years back, the open lung concept, the role of recruitment and its stabilization. So what is recruitment maneuver? It is a sustained increase in the airway pressure with the goal to open collapsed lung tissue, after which sufficient PEEP is applied to maintain those alveoli open. So, but limitations, it can cause hyperventilation in a normal aerated area versus recruitment in a collapsed area, can cause hemodynamic compromise, can cause baro and biotrauma in those areas which are already inflated and getting hyperinflated, and sometimes it has got no effect on oxygenation at all. So there are different paper about the recruitment maneuver and the PEEP. In patients with moderate to severe ARDS, a strategy with lung recruitment and titrated PEEP compared to the low PEEP in increased 28-day all-cause mortality. So these findings do not support the routine use of lung recruitment maneuver and PEEP titration in these patients. So moderate to severe patients, we should not apply. Then comes the protective ventilation. So what happens? As you can see, the picture A is showing the conventional ventilation where with the each breath alveoli is getting collapsed, and with the each inspiration the alveoli is getting over distension. So what is happening when the it is collapsing, the atelectrauma is happening. Where it is over distending, the biotrauma, barotrauma, and volutrauma is happening. But what happens in a protective ventilation? We apply a gentle PEEP so that neither alveolar is collapsing, and we give lesser tidal volume so that alveoli is neither overstretching. So that's how the came into the picture ARDS net protocol, where they have the study was there, long study was there. To cut short, as you can see, to cut short, they have given a table where we can set the PEEP according to the FiO2 ratio. Then come picture in the prone position. It was a paper which was published and showed a good mortality benefit by using the prone positioning. So the editorial came same year. That was a ProSeva trial. The editorial came into a review came into the intensive care medicine, where they have said by proning a patient, these baby lungs, this small area which was higher ventilated, can become adult. So we can increase the lung volume in these patients by proning the patients. As you can see here, there are two pictures. A is without proning and B is on the proning. As you can see, the ventilated, this is the only aerated area here. Here you can see the aerated area, volume of aerated area has gone up in the B. So in 13, this paper was published in New England Journal of Medicine, where this is called as a ProSeva study group, the prone position in severe ARDS patients. And as you can see in the prone group, the survival was quite high, and it was a significant. So out of total 237 patients were assigned to the prone group, 229 patients were assigned to be supine group. 28-day mortality was 16% in the prone group and 32% in the supine group. So just imagine, and it was a significant p value. So just imagine, mortality was halved by the proning. So, prone position reduces lower interdependence, promotes alveolar recruitment, redistribution of ventilation towards dorsal area, elimination of compression of lung by heart, lower incidence of ventilator induced lung injury by reducing parenchymal lung stress and strain. Potential problems could be the airway security because we are proning the patient, raised intracranial pressure, dislodging of the invasive lines, pressure ulcers over the face, over the chest wall, abdomen, thighs, etc. Facial edema and the nerve compression injury can happen. Then comes the effect of the neuromuscular blockers in the acute respiratory distress syndrome. So, a 3 ml rapid intravenous infusion of 15 milligram of cisatracurium or placebo was administered and assessed in these patients. In conclusion, multicenter trial provides evidence that administration of neuromuscular blocking agents early in the course of severe ARDS managed with the low tidal volume may improve outcome. But it is, mind you, it is a early course of the ARDS. Certain rescue therapies are there. As we all know, the ECMO is there. ECMO is extracorporeal membrane oxygenation. It is done, could be done as a veno-venous in ARDS, could be done arteriovenous, but in ARDS we do a veno-venous where we take out a blood from a vein, like most of the time it is the femoral vein, goes through the pump, goes through the oxygenation and oxygenator, and from oxygenator the oxygen is diffused in and CO2 is taken out, and then this oxygenated blood and oxygenated blood is pumped back into the patient through the internal jugular vein. So this is how we do the ECMO in nutshell. Severe hypoxemia, where FiO2 is more than 80, PF ratio to FiO2 ratio is more less than 80, despite high level of the PEEP for at least 6 hours in patients with potentially reversible respiratory failure is the indication. Uncompensated hypercapnia with acidemia, pH less than 7.15, and excessive high plateau pressure more than 35 to 45. So this is the different regime and different indications, and any condition, the contraindications are any condition that preclude the use of anticoagulation in these patients. Then this came the Caesar trial about the efficacy and economic assessment of conventional ventilation support versus extracorporeal membrane oxygenation in multi-center randomized trial was published, and as you can see, they recommended transferring the adult patients with severe but potentially reversible respiratory failure whose Murray score exceeds 3 or who have pH of less than 7.2 on optimal conventional management to a center with an ECMO based management protocol to significantly improve survival without disability. This paper was published in New England Journal in 18 by Dr. Ellen Coombs about the mm, rescue therapy. So, among patients with very severe ARDS, 60-day mortality was not significantly lower with ECMO than the strategy of conventional mechanical ventilation that included ECMO as a rescue therapy. So, this study was a negative study. High frequency of oscillator ventilation. It was uh, there in 90s or 200. Then after two trials were published, Oscar and Oscillate trial, which showed no mortality benefits. So this methodology is now mainly used in the pediatric, not in the adults. So high frequency oscillation in adult is out of date. Hardly any center is using. So I should not go into the detail of this. Coming to another important aspect of the fluid management in acute respiratory distress syndrome patients, this paper was published of restrictive therapy around 10, 12 years or 15 years back, where they have shown that there was no difference in the primary outcome 60-day mortality, but conservative strategy of fluid management improved lung function and shortened the duration of mechanical ventilation and ICU stay without increasing non-pulmonary organ failure. So finally, if we look at the Berlin definition, mild ARDS, moderate ARDS, and severe ARDS, this is the little cartoon, or this is the diagram how we can do. We have the low tidal volume ventilation is recommended all through. The low to moderate PEEP is recommended up to the 150 of PF ratio. Around 200 to more less than PF ratio, we can use the higher PEEP. These yellow ones are those who are still not shown any mortality benefit but are being used. Prone position has definitely shown mortality benefit, but in patients where PF ratio is less than 100 or around 100. Non-invasive ventilation is restricted to PF ratio up to 200. Neuromuscular blocking agents, again in a severe cases. In severe cases, one can use ECMO or extracorporeal CO2 removal. So I would skip this slide. These are the formal guidelines. These are published in 2019. Paper was published, as you can see here, early management of the ARDS in 2019, what they have said. So initiate mechanical ventilation, assess the ventilator strategy every 24 hours. Tidal volume around 6 ml per kg of predicted body weight in absence of severe metabolic acidosis. Systemic screening of ARDS diagnostic criteria should be done. Tidal volume 6 ml per kg body weight of predicted body weight, not current body weight, predicted body weight as per the height. Plateau pressure less than 30 millimeter centimeter of water, PEEP more than 5 centimeter of water, and check for hypercapnia. PF ratio more than 200, high level of the less than 200, high level of the PEEP if it improves oxygenation. PF ratio less than 150, neuromuscular blocking agents and prone positioning. PF ratio less than 80, discuss VV ECMO. So finally, several decades of intensive research collecting a huge amount of animal and human data have helped modify the clinical management of patients with ARDS with a probable decrease in the overall mortality. The main goal of management should be reduce as much as possible any potential harmful effect of mechanical ventilation while ensuring the adequate gas exchange. Target of oxygenation, PEEP level, and use of adjuvant therapies such as prone positioning or neuromuscular blocker should be individualized in each patient. Use of ECMO should be considered in selected patients with reversible disease. With this, I would like to thank you all for patient hearing.
Thank you so much, sir, for the wonderful presentation. We do have some question if you like to take that up.
Yeah, please.
So, sir, the first question is, what are the early signs and symptoms of ARDS that clinicians should look for the high risk patient?
The earliest sign and symptom is the tachypnea, the presence of bilateral infiltrates in the X-ray. They are the early signs.
Next question is, sir, what are the risk and complication associated with ECMO in ARDS and how can they be managed?
So in ECMO, what happens? The risks are common to any other indication, like the bleeding. The risk in cannulation can happen bleeding later on because patient is anticoagulated. Can happen bleeding can occur. Then the risk of intracerebral hemorrhage is always there. Risk of non coming out, like when ECMO dependence is always there. These are the, and infection, of course, infection is there. Multi-organ going into multi-organ failure could be another possibility, not directly linked to the ECMO, but overall deterioration of the patient can lead to that. Avoiding, we have to do a consider we have to do a um, strict monitoring of this APTT, INR, and or ACT, whatever prevalent in that center. Strict asepsis precaution should be done, and we have to wait for the lung recovery. That's why because of the high complication, the ECMO is restricted only to the select group of the patient, where the otherwise severe ARDS, the mortality is very high. So in those patients where mortality is very high, we just go for ECMO. Otherwise, in those patients where mortality is not very high, the probable death of risk of death is not high, we should not go for ECMO.
So, there's one last question. What adaptation in ARDS management are necessary for patient with comorbidities?
I don't think so. There is any specific adaptation. What I would say, the gentle ventilation and early proning could change the fate.
Thank you so much, sir, for answering all our questions. That's all from our audience. So, sir, before concluding, any take home message from your end?
ARDS is a dreadful disease, so please be careful while managing ARDS. And if you feel that you are lacking the mm, expertise, please take help of somebody who is well versed with the management of these patients. Thank you.
Thank you so much, sir, for joining us today. With your permission, I would like to conclude today's session. Thank you.
Okay.